Hello, and welcome to this episode of In Discussion With from Pharmacy Update Online. Today I'm talking to Dr. Rita Shane about why medication reconciliation should be done by pharmacy staff and how they made this happen in California. Please, could you start by introducing yourself?
My name is Rita Shane. I'm Vice President and Chief Pharmacy Officer at Cedars-Sinai Medical Center in Los Angeles, California.
And can you give us a brief overview of your role, what your current job involves?
I'm responsible for the scope of pharmacy services across Cedars-Sinai Medical Center and also have oversight of our medical network, which is provider-based clinics throughout Southern California. In addition, we have cancer centers, and I also work very closely with our affiliated hospitals and one of our community hospitals that we own. So pretty much medication management across the system.
Now, you recently presented a national call to action at the ASHP mid-year clinical meeting in Las Vegas. You called on pharmacists to take on the task of providing medication lists when patients are admitted or discharged from hospital. Now, many people think this is a good idea, but you've gone one step further, and I understand that this has now been signed into law in the state of California as a result of your sustained campaign of advocacy. And this is what I'd like to talk about today. But could you start by explaining what made you embark on this project? Why was it important to you?
So in 1998, my father had a brain metastases due to lung cancer. And after a craniotomy, he started to manifest in what I would call intractable agitation. Very difficult to control. He was on oncology ward here at our medical center, was transferred to a geropsych unit at another organization, medical center, and got worse. And it didn't make sense to me. They had to put him in restraint. So I spoke to the physician on the unit and said, could you give me some background as to what happened when he was admitted? Why is he worse? What meds is he on? And as the physician went through the med list, it became apparent to me that they DC'd his steroid, and he had been on a steroid taper as a result of the craniotomy. And I said, wait a minute, I knew you can't just cold turkey discontinue a steroid in a patient. Ultimately, I had him transferred back to Cedars-Sinai because he ended up febrile. He was getting a decubitus, and I was concerned that he would die of sepsis in a geropsych unit due to what I considered an iatrogenic issue. And that was 1998. He died in September of 1998. And I said to myself, I'm going to fix this before I retire. We were still in a paper world, but nevertheless, this lack of an inaccurate medication list upon his admission was so compelling to me as a reason to try to ensure this never happened to another patient, that I determined that somehow I would make a difference or I would focus on making a change that would make a difference for other vulnerable patients.
Could you just clarify for those of us outside the US, what is a medical assistant?
Medical assistants in the US generally work in physician practice settings in the clinics. They help support intake, blood pressure. They take medication histories. They can do some injections. So they are really there to support the physician's practice setting. It's an important role. And with the advent of electronic health records, they were given responsibility to support physicians with various order entry functions, including medications.
Are all medication transitions potentially risky? And how does the poly problem play into this?
With the advent of electronic health records, this problem with medication lists actually became more of a challenge, because the way that the orders are essentially created is through a medication history that is obtained at any encounter that a patient has if they're on the same electronic health record. And so, for example, in a physician office setting, a medical assistant will be taking a medication history. Now, in the US, medical assistants who are credentialed can enter medication information into the electronic health record. Even medical assistants who aren't credentialed, if they've been signed off through an attestation by a physician that they've been practicing for 2 years and have passed some continuing education programs, they're allowed to also enter medication orders into the electronic health record. Those orders become the basis of admitting orders in the hospital or any other orders in any encounter the patient has if they're on the same electronic health record. Now, a medication order is a sentence. And just as we learned in grammar school, sentences have to be constructed in a certain way, medication orders are similarly, there needs to be the drug, the dose, the dosage form, the route, the rate, if it's an infusion, the duration, all of those matter. And yet, by and large, most individuals that obtain medication histories in the usual ambulatory care encounters, a doctor's office or a clinic, are not trained in pharmacology to the extent we as pharmacists are, nor do they understand all of the elements of this medication order sentence. So errors are introduced. When we first implemented our electronic health record, we would see orders like methotrexate daily that the pharmacist would intercept. And that's really just a lack of knowledge and skills on the part of people that are transcribing orders without the benefit of the clinical knowledge. What creates even a more complexity is the majority of patients, especially those over 65, might have multiple chronic diseases. So multiple chronic diseases may result, and often does, in multiple physicians writing orders for medications. Hence, I call it the poly problem: polydisease, polydoc, polypharmacy. And really, the pharmacist serves as what I call the guardian angel over this process. Our role is to ensure that the treatment plan that was developed by the physician or other healthcare provider, we have nurse practitioners and physician assistants who work under the supervision of physicians, are carried out with the intent that provider had. So we interpret those orders. We make sure the medication order is correct in the context of the whole patient. And in this setting of the poly problem, we're kind of the guardian, I call it the guardian angel, but we're really responsible for that element, making sure those orders are complete and accurate in the context of the patient.
Mm-hmm. So far, so good. So what was the next step? How did you get started?
The process of bringing this to light required a combination of different strategies. One was a review of the available evidence. What does the evidence say with respect to errors on medication, histories upon admission, and discharge? Actually, as I embarked on this journey, it was really looking at the evidence. And then we did have an opportunity, because we had a very interested physician to conduct our own research, to look at, what does the data really show within our own organization in terms of errors on medication lists on admission. So we did a randomized control trial in the emergency department with the support and approval of the emergency department, because they were interested as well. Just imagine the setting in every emergency department everywhere. The patients are very sick. Generally, there are lots of patients waiting to see the physician. And the emergency department's physician's ability to create a treatment plan at that moment is dependent on knowing what the medications the patients are on, because that could be the reason for the emergency department visit. So we undertook this study, randomized control trial, using usual care, which would be the nurse or the physician who would take the history, versus a pharmacist or a pharmacy technician, a trained technician. And we found that pharmacists and technicians were much more accurate, because busy physicians and nurses are trying to stabilize the patient in the emergency department. In fact, there were up to 8 errors per high-risk patient. We focused on high-risk patients because those are the ones that are the most vulnerable. They're the ones who often have this poly problem, and we wanted to be able to risk stratify the patients who had the most potential impact on what the emergency department clinical staff would need to know. Meaning, if we could get the medication list accurate, the nurses and physicians would have a better understanding of what the patient was presenting with, so that if medications were a consideration as part of the reason for the visit, that would be, they would have more confidence in understanding what the patient was on. So that study helped contribute to the body of evidence. And I began educating about this through a California Hospital Association Medication Safety Committee that I had been asked to join, which was a multidisciplinary committee. And this was a hot topic because it was also a regulatory requirement. And throughout the country, people have been struggling with how to get medication reconciliation completed, both at admission and discharge. But I really focused on admission initially, kind of in this journey.
Yes, that leads me on to my next question. Why did you focus specifically on medication reconciliation at admission?
And thinking through how to achieve a positive outcome, meaning how to get to win, it became clear to me that if I tried to tackle both admission and discharge, I would lose the ability to influence first the regulatory bodies, and then ultimately we'll talk a little bit about the legislative process that occurred. So in my initial attempts at education, besides the California Hospital Association, I also asked the state board for the opportunity to discuss this, because our state board in California has been very, very supportive of advancing the role of the pharmacist to support the health of our public, our consumers throughout the state of California. And so in the education, I worked with my team at creating an infographic about the growing body of evidence of errors across all transitions of care, and focusing on if an error starts at admission, or if the error is actually seated in the initial medication history because of misunderstanding what medications patients are on, it will then be continued during the admission, and it will go all the way to discharge. So an error in a prior to admission list then results in a post-discharge error. So we promulgate this problem across every phase of care. So it made sense we need to fix it up front first.
And what was the business case?
The business case for having pharmacy staff involved in medication lists were based both on the cost of harm, published data demonstrating the cost of an adverse drug event. If we have someone admitted for, let's say, an excessively high dose of lithium, and that drug is continued, then we're actually going to have harm. We're going to increase length of stay, and the data shows that an ADE can increase length of stay by 3.1 days. Cost per an admission or a readmission, if these errors continue post-discharge because they're not intercepted at the beginning. At the time we did the evaluation, was $12,000 to $14,000. So it's a substantial amount of dollars when we look at the cost of harm. But then the benefits were also reduction in nursing time. So published data demonstrated about 40 minutes of nursing time spent per patient. That's a lot of time, especially if there are multiple admissions. And there was a publication that demonstrated, at least in one organization, utilizing technicians saved them $830,000. So we were able to demonstrate some concrete quantitative outcomes, as well as enabling clinicians to practice at the highest level of their license and training. So leveraging technicians who could accurately transcribe this information into the electronic health record was far more cost effective than nursing time and physician time spent on this function.
So you had all the evidence in place. Could you talk us through the process of how you started educating everybody else about this issue, and how you claimed ownership of the issue for pharmacy?
I had a wonderful opportunity since I was on Medication Safety Committee overseen by our California Hospital Association, which is a multidisciplinary committee focused on safety, to kind of share what we'd found through the evidence-based review as well as our own research. We also actually created a second infographic just demonstrating that up to 70% of medication lists contain errors. And data also supported that leveraging pharmacy staff can prevent these errors and harm, as well as freeing up time for clinicians. So I think part of the business case was we're going to ensure accuracy and at the same time enable other members of the care team, be it physicians or nurses, to spend more time with the patient. And whether it's the emergency department or in the acute care setting, these days acute care settings are ICUs. I feel like we're just running a big ICU. There aren't just ICU beds. Patients are very ill. So that education was important not only for the CHA Med Safety Committee I just mentioned, but for the State Board of Pharmacy, because I'd actually hoped that we could accomplish my goal, which was to designate the owner of the medication list upon admission as the pharmacy staff. We had evidence showing that pharmacists and technicians are accurate, both more accurate than usual care, because that's our area of focus. And therefore, it made sense to actually specify that in the State Board of Pharmacy law. The Joint Commission, which created a standard for medication reconciliation in the early 2000s, never designated an owner. It basically designated the requirement, and it was a national patient safety goal, but there wasn't an owner. And I happen to have the opportunity to comment on that because I was on the Joint Commission's Hospital Professional Technical Advisory Committee as a member designated by ASHP. And I remember having a discussion with the other members of the committee saying the problem with this requirement is that there's no owner. And when there's no owner, everyone thinks someone else is going to do it and it's not done. So given the evidence that pharmacists and technicians were better than usual care, because this is our area of expertise and focus, it made sense that this should be specified, at least in the state of California, in the law, with my hope that if we did it, other states would follow. As it turned out, the state board was in total support of the concept, but said that it would require legislation, that it was not within the scope. It was not possible to do it within the regulatory framework.
So can we pick that up? You said that it required legislation. So how did you go about ensuring that the necessary legislation was in place?
As it turned out, one of our professional colleagues knew a senator who happened to be a pharmacist. So timing is everything. I had been going through this educational journey, had gotten support from the state board, and lo and behold, the stars were aligned. And there was a senator interested in pursuing legislation to support pharmacy practice in the state of California. So we found this out in December. At the time, it was December, end of 2017, and got on a call. We were actually at the ASHP mid-year meeting and went to one of my team members' rooms. I remember talking to the senator, and he said, come to my office and let's talk more. And so he had wanted to introduce a number of bills. We went to his office. He was really enthusiastic. We already had the infographic, the evidence-based review demonstrating the problem, the solution, and the benefits. And he said, okay, write up a bill, have it in my office by January 3rd, and I will introduce it. This was December 19th. I remember, I had in my mind what I needed to put together. Obviously, I'd been working on this by then I'd been doing educational sessions for a few years to different stakeholders, some of which I've mentioned. And I ended up writing a bill. I remember it was actually New Year's and I had a cold and a glass of cognac. I think that actually helped stimulate my thinking. Anyway, the bill landed in his office and he introduced the bill. And I had the opportunity and privilege of going to a number of different hearings in Sacramento, which is where our capital is. And in September of 2018, the governor signed the bill into law. It was signed within 20 years and 4 days of my father's passing. So I've always dedicated the bill to my father. So it took 2 decades from the time I promised myself that I would do something. So I was thrilled. Senator was thrilled, and it was an exciting journey and really outstanding opportunity to educate legislators. So I would say that when I reflect on what was validating is there wasn't a legislator I talked to, because sometimes I'd meet with a legislator in their office before the hearing. And even during the hearing, everyone seemed to have an example of a family member having a problem with an inaccurate medication list. And that brought it home, because they would go, anyone that goes to a doctor's office, including myself, always says, no, I'm not on that. No, I'm not taking that anymore. I took that antibiotic 3 years ago. Please remove it from my list.
That must have felt pretty good. Take us on to January 2019. What happened then?
The law went into effect, and it said that the hospital shall establish criteria regarding who is a high-risk patient for the purposes of this section. And it states that a pharmacist or a pharmacy technician or intern at a hospital pharmacy shall obtain an accurate medication profile or list for each high-risk patient upon admission. So that went into law. And I had committed that we would study the impact of the bill. So we then hosted a webinar statewide through the CHA. Also, CSHP was a part of that. That's our California State Health System organization for pharmacy practice, and recruited hospitals to participate in a study to measure the impact of the bill. And we were able to recruit 11 hospitals, both university-based hospitals and community-based hospitals, just to demonstrate that this bill had an impact across different types of entities. We spent, the better part of that year planning, and then over the course of 6 weeks, we had a standardized methodology that we'd work through and planned for data collection. Each hospital determined their own high-risk criteria, because we don't believe that we can come up with a standardized list, because it could be a cancer hospital, it could be a hospital with a lot of pediatric patients. And we published a study, and we have outcomes. The across these hospitals over 6 weeks, 2,300 medication histories were obtained. Approximately 16,000 errors were captured. 94% of medication lists had at least one error, and 25% of errors were serious or life-threatening. We had physicians at each site who evaluated the errors for potential harm, those that were felt to be the most significant, so that it wasn't a pharmacist independently saying, I think this is a serious or life-threatening error. There was a second pharmacist, or in the case of a technician, there was a pharmacist review. So it was, what is the severity that the individual taking the history determined could have occurred? A second individual independently evaluating that. And for the most serious errors or life-threatening errors, physicians reviewed a sample of those, either 10% or I think 100 during the study. And we demonstrated that we prevented significant harm in the state of California for the hospitals that implemented this new law.
Now, SB 1254, the piece of legislation concerned, covered only medications reconciliation on admission. What about the transfer of care at discharge? Or had all the problems been ironed out by the MedRec on admission?
We continued to see errors at discharge, despite the medication histories being taken in high-risk patients upon admission. And in fact, we saw an average of 2 errors in a high-risk patient at discharge, based on studies we did internally. And in reviewing the literature, we continued to see that we still had the other end to complete. The analogy I used over the course of the next few years was, we would get, I've always said MedRec is really WRECK, because the lack of ownership and this vulnerability to each phase of care just creates potential for harm post-discharge. So I've actually, in my education, have used examples of a beautiful car that comes in that's been totaled. And then we put all of our resources into fixing this car. So, imagine your favorite car in your favorite color that has just been totaled, and we fix it, and it's as good as new. And then we drive it off a cliff, because we haven't fixed the back end. Or maybe the car goes home and gets into an accident because there's something that was continued at discharge or omitted, and now the patient's or the car is back in the body shop. I call the hospital a body shop because if you think about it, unless someone's having a baby, a hospital admission is a mistake. Something went wrong. And so we fix it during our, 5, 6, 7 days, however long the length of stay is. And then we don't fix if we don't fix the medication list, 20% of those patients could end up back in the hospital because 20% of admissions are medication related, and the data also demonstrate that at least 40% of patients have an error on their medication list at discharge. We have defined high alert medications globally. I can ask anyone anywhere in the country, in this country or any country, what high alert drugs are, and I'll get 3, 4, 5. It occurs to me that patients are also high alert, especially if we reflect back on the poly problem with patients with multiple diseases on multiple drugs, multiple providers. And if we really wanted to improve the care of our patients, especially the most vulnerable, it would be in our best interest to define the high alert patient. And if we did that globally, then those patients would be tagged, and we would ensure that there's focused attention on those patients across providers. But in particular, pharmacists could own those patients. Those would be the ones that would be prioritized to ensure that medication lists are accurate and that any changes that are needed, including deprescribing, became a priority. Because my belief is maybe after so many years in practice, the patients are probably on 20 to 30% more medications they need, especially the ones that I would point as high alert. So that's kind of one of my dreams. So when we look at this high risk or high alert population, there is a need to ensure that they have a safe landing. So we don't have this med wreck, WRECK, and this beautiful car or patient that we have prepared for discharge, but then inadvertently introduce errors during this post-discharge episode.
Mm-hmm. So you've described the problem. How did you tackle the discharge issue?
I was struggling with how to add discharge to this language that we had created, that the state board adopted, ensuring accurate medication lists at admission for high-risk patients. And it occurred to me that perhaps this could be accomplished through a regulatory change. Maybe it didn't need another round with the legislature. In January of 2025, we had an opportunity through the California Hospital Association, again, to meet with the executive officer and president of the State Board of Pharmacy to just talk about hospital-based practice. They were interested in learning more, and they were invited to attend a meeting, and a number of us flew up to Sacramento, and we were really answering questions they had, sharing some of the differences between hospital-based pharmacy and community pharmacy. And I took the opportunity to ask the state board how we might pursue adding and discharge to the existing law. That could it possibly done without legislative change, given the problem and the evidence around the discharge episode, hospitals focus around the country and reducing readmissions, and this being really, again, a public health issue because we can't ensure the safety of patients post-discharge given the prevalence of errors at discharge. And furthermore, community pharmacists are then in a position of promulgating an error that's introduced due to an erroneous prescription or an omission of prescription. Anticoagulants omitted upon discharge, antibiotics omitted upon discharge occur relatively frequently, inadvertently, but they occur. And so a community pharmacist who may not have access to the electronic health record doesn't have the context to recognize when something is omitted or an error is introduced. That dose may not be the right dose for that patient given their renal function, hepatic function, et cetera. So my rationale in speaking to the state board was if we were able to add and discharge to the existing law, we would also support the community pharmacists. So it was really a win-win for everyone, the patient and pharmacists at discharge who were reviewing this, as well as the community pharmacists who are often filling prescriptions. So they said, why don't you come to a meeting? They had an April board meeting scheduled, and they said they would allocate time for education. Our state board is very open to education. One can introduce a topic at any state board meeting for a future meeting that is felt to be important from a patient safety perspective, or an issue that a pharmacist wants the state board to discuss. So we have opportunities to educate, and I've been able to do that several times in my career, where I've said, would it be possible to have a discussion about something? And they'll schedule it for a subsequent meeting. In this case, it was actually the state board executive officer and president who said, come into a meeting and educate us. So I remember April, I showed up promptly, and I had a 20-minute presentation, and I sat there for an hour because there were so many questions from the state board members themselves. And our state board has a proportion of members that are not clinicians. In fact, that's by design, because they are charged with protecting the health of the state of California, consumers, patients, public. And so it was actually fun, because the questions that were from the non-clinicians on the board were representative of their own personal experiences with inaccurate medication lists. And so my 20-minute presentation ended up with me sitting there for an hour. And there were questions from different parts of the state, because this is a WebEx type of a platform. Anyway, suffice to say that it was very well received. As it turned out, the state board was going through what is called a sunset review, which is a review that occurs periodically at the state level. I believe it occurs in other states as well, where every profession, whether it's medicine, pharmacy, dentistry, physical therapy, the like, there's a review of their laws. There are any changes that need to be made, edits, language clarification, and minor modifications that goes through the sunset review. It's actually a comprehensive process. I think it was a 30 or 40-page document. And the state board voted unanimously to add "and discharge" to existing language. So that's how the regulatory pathway, which I didn't realize how it works, but the timing was such they were able to add it to the sunset review that was already under review. It had been, I think, introduced in March, but they were still making edits to it based on state board feedback. So they added in "and discharge." So this 30+ page document was ultimately presented to the governor for signature. And there was no resistance to it, since this has to go through all the hearings as does legislative. In fact, this was a bill. It was part of AB 1503, I believe, was the name of the bill. So it was an assembly bill. So it is a formal legislative process, but it wasn't just for this one thing. It was part of this 30-page review.
Mm-hmm. I understand that the new law came into force on January the 1st, 2026. Congratulations. You described your presentation at the mid-year as a national call to action. So where do you go next with this?
Well, my vision was always that we would create the toolkit to enable other states to go ahead and adopt this, since we've kind of created model legislation. And I think there's discussion going. There has been ever since the initial SB 1254 for medication histories upon admission. That being said, I am pursuing what pathway could be used to get this as model language at the national level. So we have a National Association of Boards of Pharmacy, and I've spoken both to our executive officer of the California State Board, as well as to the folks at ASHP about how do we pursue model legislation. And there's interest in both parties. So my next goal is to see if there's an opportunity to educate an ABP about this, either through the executive officer, which I'd love her to have the opportunity to do it, because she's been a key supporter, and California should get credit for this, for really looking at a problem that exists across every patient who's on medications. I mean, we're targeting high-risk patients, but in my experience, anyone who's on medications needs to have an accurate list. I mean, even if someone has one disease and condition and doesn't meet the threshold of a high alert patient, they deserve an accurate list. And so I would love to see this nationally, and I will continue to pursue that and persevere, which is kind of a key attribute that I possess. I don't give up. I do enjoy educating about problems where the evidence supports that we can come up with actionable solutions that make sense. So I think the next steps is to continue to educate and broaden the message to more and more stakeholders. I have also, on multiple occasions, talked to the Joint Commission about this. They're going through changes in their priorities and such, and so they had an interest in it. However, I also have to be respectful of their priorities. So somewhere, somehow, I'm hoping we can see this become a national requirement.
Dr. Rita Shane, thank you very much for talking to us about this important issue that really has been terrifically interesting. For more information about Dr. Shane's work, please visit the website using the links in the description. And please subscribe for more news, videos, journals, and podcasts. For updates straight to your inbox, please follow the links below. And thanks for watching.